Today's lecture is on congenital anomalies. Congenital anomalies are something that baby is born with that's not considered normal form or function. Now, when I say that, do not mistake congenital for genetic anomalies. Not all of these are tied to genetics or a problem with the DNA. They are just issues that may have occurred during the baby's development. You know, all those things we talked about in fetal lung development and in maternal history and how the baby is developed. One little thing goes wrong, okay, and any of these anomalies could occur. So we're going to go into some of them, definitely not going to go over all of them. You are definitely going to see other things if you go into neonatal pediatrics or when you are at children's. There's other disorders that you may see or other anomalies you may see. But we're going to do an overview of them, kind of the most common. So the first one we're going to talk about is esophageal atresia. Okay, so esophageal atresia is when the esophagus is closed where it would normally be open. Okay, so atresia is defined as the pathological closing of a normal opening. This happens in 1 out of 3,000 births. 345 are preemies, and 50% of the time, other problems are present, either heart defects, imperforate anus, which means there's no opening at the anus to the outside. So esophageal atresia is an indication that there might be other formative defects or anomalies going on. So I'm gonna pull up a video on esophageal atresia so you can see what it looks like.
Esophageal atresia, or EA, occurs when a baby is born with their esophagus in discontinuity, or with a gap. Usually, the esophagus forms as a tube that connects the mouth to the stomach. In babies with EA, the esophagus develops in two separate segments that don't connect to each other. In some children, so much of the esophagus is missing that the ends cannot be easily connected with surgery. This is known as long gap EA. Many babies born with EA also have a tracheoesophageal fistula, or TEF. This is an abnormal connection between the esophagus and the trachea, which is the tube that connects the throat to the windpipe and lungs. There are 4 types of EA. In type A, the upper and lower segments of the esophagus end in pouches, like dead-end streets that don't connect. A TEF is not present. In type B, the lower segment ends in a blind pouch. The TEF is present on the upper segment. This type is very rare. In type C, the most common type, the upper segment ends in a blind pouch and a TEF is present on the lower segment. And in type D, a TEF is present on both the upper and lower segments. This is the rarest form of a EA-TEF spectrum. Because of their anatomy, children with EA can't receive enough nutrition by mouth. It can also be more prone to respiratory infections, like pneumonia. That's why the best treatment for EA is usually surgery to reconnect the two ends of the baby's esophagus to each other. The Esophageal and Airway Treatment Center, Boston Children's Hospital, is one of the only programs in the country specifically designed to care for children with all forms of EA. We offer 2 innovative surgical approaches to long gap esophageal atresia. In the next 2 videos, I'll tell you more about these 2 procedures, the focal process and the new minimally invasive version of the focal process.
All right, so that gave you those 4 types of esophageal atresia. As we talked about in the video, most types occur with some type of fistula or a connection between the esophagus that is there and the trachea. Biggest risk is aspiration. Even if there's no connection and that baby or that child's not getting any nutrition from above, still gastric contents, that acidic gastric liquid can be aspirated, and that is pretty risky. So if you look in your book, if you have the textbook, figure 8-1 on page 266. A is the most common, with the esophagus ending in a blind pouch with a tracheal esophageal fistula on the lower end. B, the esophageal atresia without fistula. C is the H type, where there's no break in the esophagus, but there is a connection between the esophagus and the trachea. And then D and E. Here's your book. Okay, so these show the different kinds. He talked about 4 kinds. Your book shows 5 kinds. Regardless, there's an abnormal connection. You guys don't need to know the different kinds. You need to know what happens in tracheal esophageal fistula. Okay, the esophagus at some point ends in a blind pouch. It may or may not have a connection with the trachea, and the biggest risk is aspiration for sure. Symptoms of tracheoesophageal anomalies or tracheoesophageal fistula, or TEF, you're going to see it abbreviated, are accumulation of secretions in the mouth. Okay, so those secretions are not being swallowed, or if they are being swallowed, they're ending in a blind pouch and they're building up and then they're pouring out of the mouth. So hypersecretions in the mouth. Sporadic respiratory distress, usually coinciding with feedings because they're aspirating. And then repeated regurgitation of feedings, so they vomit a lot. An insertion of NG tube is helpful to diagnose the problem. If it cannot be gently passed, then more tests are indicated. Before surgical correction, you keep a patient at a 30-degree angle to prevent aspiration. Aspiration pneumonia, as they said in the video, and I said also, is the hazard of the condition. Okay, so aspiration pneumonia is pretty prevalent with these kids. And then surgical correction is how we fix it.
Esophageal atresia, or EA, is a condition in which the esophagus is not connected to itself when a child is born. When the gap between the 2 ends of the esophagus is too far apart, it is called long gap EA. When possible, the best treatment option for a long gap EA is to try to preserve the esophagus. That's why we recommend the focal process whenever the ends are too far apart to put together at the first attempt. This technique aims to close the gap by growing the esophagus. In the focal process, a surgeon makes a small incision in your child's back and then places a series of sutures or stitches on the upper and lower ends of their esophagus. These stitches connect the ends to a traction system that is on the outside of your child's body. Over the course of about 1 to 3 weeks, your child's clinician will increase the tension on the sutures bit by bit. This causes each end of the esophagus to grow about 1 to 2 millimeters each day, just like a muscle grows when you exercise it. As a result, the esophagus will grow enough for your child's surgeon to attach the 2 ends. During this process, your baby will need to be motionless. That's because excessive motion might break or pull out the sutures. They will stay in the intensive care unit on a ventilator, a breathing machine, and will be given medication to help them stay still and comfortable. Once the esophagus has grown to the desired length, the surgeon will remove the sutures and sew together the 2 ends of the esophagus. Almost all of the patients treated with this method to date are able to eat and swallow, and the new esophagus typically looks and works like one that developed normally. Since 2009, Boston children's surgeons have been the pioneers and strongest proponents of the focal process. As a result, families from all over the world come to us for our expertise in this technique. Recently, Boston children's surgeons have developed a new minimally invasive approach to the focal process that does not require the child to be asleep and still while the esophagus is growing on traction. I'll tell you more about that in our next and final video.
So if you want to learn more about that, you can look up that last video that you talked about, but we're not going to watch another one on this today. So that's tracheoesophageal fistula or tracheoesophageal anomalies. Again, you just need to know that it's an abnormal or lack of connection where they're supposed to be. And the big risk is aspiration. Next thing we're going to talk about is choanal atresia. Now, choanal atresia is when the opening to the oropharynx from the nose is blocked by a thick membrane that's formed across the opening. Many times it's unilateral. Okay, so it's only occurring on one side. So it kind of goes undiagnosed for a period of time. If it's bilateral, it is a medical emergency because babies are obligate nose breathers. Okay, we've talked about that, all the way through the program. If babies are obligate nose breathers and their nasal passages are blocked by a membrane, well, then they're going to go into respiratory distress and they're going to gasp. They also risk aspiration while they're eating because they will be trying to suck from that bottle or breastfeed, and they can't breathe through their nose. So then their mouth fills with formula, and then they gasp and they can aspirate that. So it is a medical emergency, especially if it is bilateral or both sides. If it's unilateral, it's not necessarily a medical emergency, but does need to get corrected.
Hello, this is a case of a bilateral choanal atresia. This child had only in the left side nasal cavity only a small hole in order to try to breathe and in order to try to drain the secretions on the left side nasal cavity. This is the endoscopy of the right side nasal cavity. As you can see, there is a complete choanal atresia, a lot of secretions that was on the nasal cavity. And this is a complete because it has bone and it has mucosa. In the left side, this is the endoscopy of the left side, you have this very small hole, and this is an incomplete atresia because it's just like mucosal. So the first step of the operation is to infiltrate in order to do a hydrodissection in order to create and to elevate the flaps, the nasal mucosal septal flaps. And in the right side, we are going to raise a flap also in the nasal floor in order to have a bigger flap. So we mark the parts of the flap, the most anterior part of the flap, the posterior part of the flap, and then the lateral parts of the flap. This right side flap is going to be pediculed at the superior part. So this is the right side flap, which is going to be pediculed at the most superior part of the nasal septum. This flap is going to be rotated to the left side. This is the crossover technique for choanal atresia. So we raise the flap, the right side nasal cavity, septal and nasal floor flap, mucosal flap, and then we expose the bony part, the posterior part, the bony part of the choanal atresia. And also we expose the posterior part of the septum because this surgery also is a posterior septectomy. You do a posterior septectomy, you open the choanal atresia, and then you rotate the flaps in order to try to avoid synechia and closure of the choana. So this is the left side nasal cavity, which we are also elevating the flap. This flap, though, is going to be pediculed at the most inferior part. So we cut the most superior part of this nasal septal flap because this flap is going to be pediculed at the nasal floor and it's going to be rotated to the right side. And then with a chisel and hammer, we create a posterior septectomy. We expose the choanal atresia, both the bony part and the mucosal part. We cauterize a little bit, and with a Garrison punch, we open this choanal atresia in all its aspects, the lateral aspects, superior aspect, and inferior aspect. And then you have to see this image, this kind of image of the rhinopharynx. So after we open the choanoatresia, we rotate the flaps. So this is the left side flap, which is going to be rotated to the right side, and this is the right side flap, which is going to be rotated to the left side. So we do a crossover flap. This right side flap was a little bit big, so we decided to cut a little bit this flap, and with the free flap of the mucosa, we also cover a small part of bone that was not covered by the flaps. So at the end, you have this flap, the right side flap, the left side flap, which is going to rotated to the right side, and then we put a little bit of mucosa to cover this exposed bone, and then we rotate the flap again in order to cover and to not leave any exposed bone in the nasal floor. And then with the remaining part of the flap, we cover this most superior part with also mucosa in order to avoid any problems with possible synechia or possible closure again. So at the end, we put some fibrin glue to hold the flaps, and then we put a Foley catheter in order to hold the flaps in position in the postoperative, immediate postoperative period. So thank you very much.
All right, so choanal atresia. Condition might be unilateral or one side. If it's unilateral, may go undiagnosed for a period of time. If it's bilateral, it's a medical emergency. It's life-threatening as babies are obligate nasal breathers, and their tongues are so large that they essentially block a baby's airway. Plus, when they're eating, they need to be able to eat and breathe at the same time while breathing through their nose. So there's nasal passages are blocked, the oral cavity fills with formula or breast milk, then they gasp to get a breath in, they aspirate. Choanal atresia is treated initially with an oral airway or intubation until surgery is possible, okay, especially bilateral choanal atresia. Okay, and then diagnosed by trying to pass a nasogastric tube. And then once they can't pass that nasogastric tube, they do soft tissue exams, further exams. It's a pretty uncomplicated repair, but something that is pretty vital to get taken care of. Great. Next thing we're going to talk about, and we have mentioned this in class. We've mentioned kind of where it happens along the fetal development train, or fetal development path, but diaphragmatic hernia. Okay, so diaphragmatic hernia is a severe life-threatening situation. Usually occurs on the left side. That's the most common side. If it is diagnosed in utero, it's corrected fairly soon after birth, within hours after birth. So in diaphragmatic hernia, during development, the diaphragm is not completely formed as a muscle, and the baby's intestines migrate into the thoracic cavity. Again, usually occurs on the left side. So the intestines are migrating up into the left chest, and where the lung would normally develop, you have intestines invading that space. Diaphragmatic hernia, if the diaphragm hole is big enough, it could include stomach and liver up into that left chest. If it's a teeny tiny diaphragmatic hernia, sometimes it goes undiagnosed. Sometimes until the diaphragm or the person grows and the diaphragmatic hole gets bigger, those intestines don't migrate up. So occasionally it goes undiagnosed, but not very often.
A congenital diaphragmatic hernia is a birth defect in which an abnormal opening in a baby's diaphragm allows abdominal organs to move into the chest. The diaphragm is a large, dome-shaped sheet of muscle that separates the chest from the abdomen. When the baby breathes in, the diaphragm and outer rib muscles contract, expanding the chest cavity. This expansion lowers the air pressure inside the chest, creating a pressure change that causes air to rush into the lungs. When the baby breathes out, the diaphragm relaxes and the inner rib muscles contract, reducing the size of the chest cavity. This reduced size increases the air pressure inside the chest, forcing air out of the lungs. For unknown reasons, the diaphragm in some babies doesn't develop completely before birth, resulting in an opening between the chest and abdomen. The most common location for this opening is on the left side of the diaphragm, near the back. The baby's abdominal organs can push through or herniate through this opening in the diaphragm and compress the lungs. As a result, the lungs do not develop fully, causing the baby to have significant trouble breathing right after birth. Before the operation, the baby will be given general anesthesia to put him or her to sleep for the entire operation. A breathing tube, inserted soon after birth through the nose or mouth and down the throat, will continue to help the baby breathe during the operation. Usually, the surgeon will make an incision under the ribs on the left side. Next, the surgeon will carefully move the abdominal organs from the chest back to their normal place in the abdomen. If the hole in the diaphragm is small, it will be closed with sutures alone. If the hole is too large or there isn't enough muscle to close it, a patch will be sewn over it. Finally, the incision will be closed with dissolvable sutures or closure tape dressing. After the operation, the baby will be taken to the neonatal intensive care unit for monitoring. A mechanical ventilator machine will help the baby breathe for a few days or several weeks. Pain medication will be given. The baby may continue to receive antibiotics through the IV. The hospital stay may last for weeks or months, depending on the size and condition of the baby's lungs. If a patch was used, the baby's growth will need close monitoring because the patch doesn't grow and may start to pull away from the hole.
All right, so here's a picture of an X-ray of a baby with diaphragmatic hernia right after birth. Right here's the lung tissue on this X-ray, and all of this is intestines. Okay, so this baby's lungs were just never developed. Okay, they are small and they are stiff because they didn't have that time for practice breathing, where the alveoli or the lungs are partially expanded and filled with fluid. Okay, it didn't have the growth of the tissue. So this baby's left lung is severely underdeveloped and compromised. Then what happens is, because that baby's being ventilated, okay, see there's an ET tube, the right lung, we have to be really careful not to hyperexpand the right lung and cause damage to the right lung while we're trying to provide oxygenation and ventilation to this baby. This is why very often babies with diaphragmatic hernia will go on high frequency ventilation or on ECMO almost immediately, because we want to minimize the damage to the non-affected side. Okay, we already have one lung that's underdeveloped and is affected, it can't expand. We don't want to damage the side that can expand. Here's a picture comparison side to side. A normal newborn anatomy here. Here's your diaphragm, nice and intact. And this is a patient with diaphragmatic hernia with intestinal involvement. Okay, so the intestines have migrated up and they're just pushing that lung. The earlier the migration, the less lung development that occurs. Okay, over here is just a zoomed in picture of this. Okay, we have intestines migrating up in the chest through the diaphragmatic hernia. See, here's the hole right here. Here's part of the diaphragm. Here's the other part of the diaphragm. Intestines are coming up. This might even be stomach involvement. It is shoving that left lung up, compressing it, even putting pressure on the heart. Okay, so it could actually affect our good side as well. So definitely a medical emergency.
Clearly, one of the benefits of the special delivery unit is the proximity of the place of the actual birth to the neonatology teams.
Prior to the special delivery unit, a baby would be born across the city, could be across the street, could be in a different town. And there were a lot of steps that had to happen to get the baby here.
And this would, of course, be very hectic for families. For dads and other family members, they would visit mom in one hospital and the baby in the other hospital. And, of course, very difficult for mom, who would physically be separated and unable to visit with her baby during this very trying time.
The SDU was designed with the knowledge that the NICU and cardiac ICU needed to be very close so that mothers could visit as frequently as they wanted, or other family members, and still receive the care that they needed from an obstetric point of view.
So everything is really brought to the family, the mother in the special delivery unit, the baby at the time of delivery, and then after birth care in the NICU.
It really allows the family to be a family from the very beginning. And it allows us to take care of the baby from the very beginning, to minimize transitions, to minimize changes, to minimize risks. And so I think it's been a great thing for both family and baby.
We've created mechanical ventilation guidelines to gently ventilate these infants with small, delicate lungs.
Gentle ventilation is a mode of ventilation which just means that you don't use more than you need.
One does not want to induce injury from the ventilation in these tiny, diminutive lungs by breathing for them with too high pressures. That can cause damage and subsequent complications and even death.
These infants, babies with CDH, are very unique. They're very delicate, and their physiology is quite brittle. They can change from minute to minute, hour to hour.
In the acute period, or initially after the baby's born, they often can seem really, really stable. We call that the honeymoon period, and it looks like things are great. And then they can start to have a spiral where just changing their diaper or having a loud noise in the room can actually make them desaturate or do something we call shunt.
They're not getting blood effectively from their heart into the pulmonary vascular system. It's bypassing the lungs entirely.
So if we have to use high pressures, or we're still have to be on high oxygen after a time period, then that's a baby that we need to give the lungs rest.
If we have that situation, we have ECMO as an option.
Extracorporeal membrane oxygenation is really a bypass for the lungs. It does the work of the lungs when the lungs are very fragile and not able to do the work.
That basically involves a surgical procedure in the intensive care nursery, putting a cannula in the common carotid artery, a cannula in the internal jugular vein. The venous blood drains out into the ECMO machine, which has an oxygenator to oxygenate the blood, and a pump that will pump the blood back to the baby through the arterial cannula.
So a baby on ECMO has a lot of equipment in the room. I think families are often a little taken aback, especially in the first day or two of life.
The first time I walked into the room when she was on ECMO, it was so hard because I looked and she was like all the way down the hall, and just see this big machine in a little tiny bed, and she was so small in comparison to all the machinery that was around her.
For a baby with a CDH on ECMO, that amount of time is on average a couple of weeks. It's longer than most of the neonatal problems that need ECMO. And it's very important that families realize that. You know, once we go on, we're usually there for a while.
Okay, so most diaphragmatic hernias, thank goodness prenatal care is so much better now. Most are diagnosed at the anatomy scan or early on in the pregnancy. There is lots more options for treatment. We are ready for that baby to be born. We know exactly what they need afterwards. So we're gonna watch two more surgeries. One is laparoscopic repair of the diaphragmatic hernia. And the other one is actually the fetal surgery procedure, which is so cool and has saved a lot of lives. And that's something that's just happened in the last 10 to 15 years. So I'm gonna pull up both of these and we're gonna watch them.
The intestines are visualized in the left chest. The scope is passed through the hernia into the abdomen. The intestine is reduced into the abdomen using atraumatic graspers. The intestine is reduced and held in place with insufflation. Cautery is used to mobilize the posterior margin of the diaphragmatic hernia defect from retroperitoneal attachments. With the diaphragmatic hernia margins now free, interrupted 2O silk or ethibond sutures are placed, starting from the medial corner. The most lateral suture is placed in a triangular fashion, incorporating the rib adjacent to the defect. The anterior leaflet then is sutured. The posterior leaflet then is sutured, and the suture is brought back out through the chest wall superior to the same rib. The knot is tied in the subcutaneous fat. The completed repair is shown.
Congenital diaphragmatic hernia is a very severe birth defect in which there is a hole in the forming diaphragm, and that then allows the contents of the abdomen, like the bowel and the stomach and even the liver sometimes, to come up into the chest.
This causes lack of space above the diaphragm, and the lungs and the heart actually get pushed to the side. So there's no room for the lungs to grow.
FETO stands for fetoscopic endoluminal tracheal occlusion, FETO. This is a study that we're currently performing at the Children's Hospital Philadelphia. It's a feasibility study, which means that we want to see if we can perform it successfully and safely in mothers who are carrying fetuses with congenital diaphragmatic hernia. The idea behind it is that a balloon is inserted into the airway to occlude the airway.
That prevents lung fluid from escaping the lungs,
which will cause a buildup of pressure.
And that pressure that's established is like a stenting force that distends the lung.
That increases the number of air sacs or alveoli, and also increases the surface area or makes the alveoli bigger.
Once they're large, we actually remove that balloon so that they can go through the normal course of maturation. The FETO study will start off with an evaluation that is standard of care for any baby with a congenital diaphragmatic hernia.
There would be a detailed telephone call in which we would gain their history information and the baby's anatomical defect information. We would bring them into our center and they would have a comprehensive one-day evaluation.
The high-resolution ultrasound, they would have the ultra-fast fetal MRI, then they would have a fetal echocardiogram, and then they would meet with the high-risk obstetricians as well as the pediatric surgeons, neonatologists, social worker, genetic counselor, and essentially all the key members of our team.
During the initial evaluation, it will be determined whether the mother and the fetus are eligible for the study, depending on certain anatomic criteria in the fetus and certain maternal factors in mom's health history. That, along with the associated potential risks for mom and for the baby, will be detailed and discussed at the counseling session.
If all criteria are met, then there's the chance that the mom would be offered this procedure.
Those who are candidates and who choose to go forward with this, it is a commitment. It's an operation under local anesthesia or sedation at 28 to 30 weeks gestation.
It's performed in much the same way as other fetoscopic procedures. A small incision is made in the uterus under ultrasound guidance, and then a trocar is placed so that it can line up with the fetal mouth. A fetal bronchoscope is passed through this trocar and then into the baby's airway. And then under direct vision, we actually blow up the balloon and then detach it and leave it in place.
Moms stay in the Philadelphia area for a good 3 to 4 weeks afterwards, so that we can prepare her for the balloon retrieval.
We need to follow really closely to watch how the lungs grow, to watch for any potential complications, to make sure that the balloon remains in place. And then towards the end of gestation, around 34 weeks, we would like to remove the balloon. Now, there's a couple ways to do this. The first and the easiest way would be if we could puncture it with a needle, and then because the pressure behind it is stronger, have it just come out of the fetal mouth. And that would be attempted. If that's not successful, if we can't just puncture it, the next step would actually be to repeat the procedure that was performed before. Again, another small incision after lining it up with where the fetal mouth will be, and then passing a fetal bronchoscope into the airway. And this time it's loaded with a grasper in order to pull that balloon out.
Families would be required to deliver at the special delivery unit at CHOP, so that there would be the multidisciplinary resources there to take care of mom and the baby when the baby is born.
The baby's immediately intubated, the baby is immediately on a ventilator, and then we go through the course of things as usual. We're trying to wean the ventilator, we're trying to wean support, and get the baby ready for surgery. All the babies will still need to have their diaphragmatic hernias repaired at some point when they're stable.
Parents should anticipate that they will have a stay in the NICU that should be, in the order of weeks, if not months. We hope that the tracheal occlusion will help to minimize some of these concerns that these neonates have right off the bat, but we are fully prepared that they are going to follow a course very similar to what a typical newborn with congenital diaphragmatic hernia faces.
In addition, we would anticipate a commitment long-term, or for, of course, those babies who survive to be followed by us with the standard of care protocol we have that goes all the way through the pulmonary hyperplasia program, which is that multidisciplinary group that's focused on children with the diaphragmatic hernia problem and all the issues they may have.
To see how they perform both neurodevelopmentally and from a cardiopulmonary standpoint. And these visits will be scheduled at 6 months, 12 months, and 2 years.
So our goal when families come to us for evaluation and consultation is that we provide them with enough information to decide what they think is the best course for their family and for their baby. And whether this is participation in the fetal trial or typical postnatal repair, we hope that we provide enough information for the family that they are making the best decision for them.
All right, so that walked you through both traditional repair of diaphragmatic hernia and the fetal surgery, which is super cool. That fetal surgery helps preserve the lung tissue on the affected side. Like I said, usually the left side, but not always. So it helped preserve that lung tissue by keeping the lungs inflated. So super cool advancements, which are increasing the chances of survival for these babies. Like any other congenital anomaly, the earlier it's detected and repaired, the better off the outcome is. All right, next thing we're going to talk about is 2 congenital defects or anomalies of the abdominal cavity. One is called omphalocele, the other one is called gastroschisis. Okay, so omphalocele is when the infant is born with intestines, liver, and sometimes other organs outside of the abdominal wall. Okay, with omphalocele, all of these vital organs are not contained in the abdominal wall, but they're born outside. With omphalocele, those organs are born in a sac, or they're contained in a sac. So they're in a little sac, but outside of the body. The contrast to omphalocele is gastroschisis. Okay, gastroschisis is still an abdominal wall defect, but there's no sac containing organs. So the infant's born with intestines, liver, sometimes other organs outside of the abdominal wall, and they're just kind of free floating in the amniotic fluid. Okay, both of them usually detected in utero or on infant prenatal scans. Both of them treated similarly, and we're going to watch repairs of both of them because you will definitely see this when you are doing your NICU rotation, but slightly different. And the difference being omphalocele, everything's contained in a membrane or sac. Gastroschisis, all kind of free floating in the amniotic fluid. So let me pull those up.
For small to moderate sized omphaloceles, as long as the baby's testing is reassuring and there's no obstetrical contraindications, those are babies that actually do better with a vaginal delivery. Babies with giant omphaloceles or omphaloceles that contain liver are a whole different issue.
It is important, in our view, for fetuses that have a large or giant omphalocele in which there is a portion or majority of the liver in the omphalocele sac to have a planned delivery by cesarean section because of the risk of dystocia or difficulty in the delivery with the giant omphalocele, or because of the risk of damage to the liver during a vaginal delivery.
Charlie was delivered by C-section and immediately rushed over here to Children's Hospital and put in the neonatal ICU.
In babies with omphaloceles, their bowel and liver are covered with a sac, and that sac is critical.
If the omphalocele sac ruptures, then the complication risk and the risk of death skyrockets.
So it's one of our top concerns when the baby's born that someone's sole responsibility is management of that omphalocele sac, while someone else's responsibility is management of the airway.
A lot of times, infants with a giant omphalocele will have small lungs and require assistance right from the moment they're delivered.
Charlie was put immediately on a ventilator and was on a ventilator for almost 2 months.
For an omphalocele, we usually wrap with a sterile dressing the entire omphalocele and then bring the baby to the intensive care nursery.
Just going to the NICU for the first time was very scary because you saw these very, very sick babies and realized that that would be you.
Once the baby is stabilized, the issue is how is the omphalocele going to be closed?
Babies with small omphalocele often are able to go to the OR and have what's known as a primary repair, which means they go to the OR one time and are able to have it closed right then and there.
Then there are infants with giant omphalocele that contain different components of bowel and liver, and those infants are a little more complicated.
There's not much abdominal capacity because virtually everything is out, particularly the liver. The majority of the liver is in the omphalocele sac. So the issue there is how you can gradually reduce the contents of the omphalocele sac back into the abdomen and eventually close it without causing harm to the baby.
You could imagine trying to slowly reduce all of those organs back in. Well, as you do that, what does it do? It pushes the diaphragm up. If you have a small chest cavity and small lungs, any kind of disturbance can just push the kid, over the edge and to a major respiratory crisis.
We use a technique which involves bringing the baby to the operating room, finding the fascia or the strength layer, 2 bands of muscle, one on each side of the omphalocele defect. then sewing a Teflon-coated mesh sheet on each side to the fascia, so you have two sheets coming up, and then you sew the sheets together, and you leave the omphalocele sac intact. Then, usually on an every other day basis, you can then crimp down on these two sheets and sew them back together so you eventually close the baby all the way.
During that time, we have to follow them very closely to make sure that with the challenges of closing the abdominal wall defect, we don't interfere or have any setbacks with their pulmonary performance.
We watch the pressures that it takes to fill their lungs with air. We expect that those pressures will be high initially, post-op, and once they begin to come down, then that tells us that the baby's ready to go back to the OR.
He went through 7 different surgeries in the course of 3 weeks. Seemed like it was every other day.
And so this can take place over a period of a week or longer, where they go to the OR every other day, every 3rd day, until final closure.
For babies with gastroschisis, the average gestational age at the time of birth is between 35 and 37 weeks gestation, where term, of course, is 40 weeks. So as a rule, these babies come early. For gastroschisis, there is no advantage to a cesarean section delivery over a vaginal delivery in most cases.
There's some physiologic benefits to being delivered vaginally. It helps to squeeze some of the fluid out of the lungs. It triggers reabsorption of fluid within the lungs. It's less risk to the mother. The recovery time is certainly much more rapid after vaginal delivery and allows the mom to be down at the bedside within hours.
Of course, if there's a maternal indication for a cesarean section, or if a stress gastroschisis fetus is having difficulty before birth, then a cesarean section might be mandatory.
It's critically important to watch these babies carefully during the labor process because they are kind of at the fringe, and some of them may not tolerate labor, and failure to recognize that they're not tolerating that labor can result in a much, much more compromised child.
When a baby with gastroschisis is born and is then moved from the delivery room immediately to the resuscitation room, we need to assess the baby's breathing status, place an IV or two, place a nasogastric tube to decompress the intestine.
It's really important to keep the bowel decompressed so that you don't have reflux of gastric contents.
There's a risk that they could then aspirate or breathe that into their lungs. So that's a really critical step.
The thing we worry about is the constrictive effect of the abdominal wall defect can cause damage to the blood supply or blood drainage from the bowel. That can lead to loss of bowel, which can be difficult to repair.
So we have to have very careful positioning of the infant, usually on their right side, to take the pressure off that area, and very close surveillance of the bowel and whatever else is out to make sure that it looks well perfused and healthy.
By the time I got in there, the baby was already, I guess, what you would call prep. They basically put plastic over his body, so this way, I guess because of infection and to keep everything moist.
The baby is started on antibiotics. And our protocol at the current time, for the most part, for uncomplicated gastroschisis, is to immediately place a spring-loaded silo. The concept is like a silo on a farm that contains grain. There's a long sheet, it's clear silastic, so you can see the intestine, and the intestine is placed sterilely into this sheet, and then the spring-loaded base then is manipulated to go inside the abdomen, and since the spring is larger, the circular spring is larger than the defect, it stays in place.
And it's suspended from the top of the baby's bed. With gravity, the bowel can then move from the silo into the abdomen.
After a day or two, we begin the process of daily reductions, where they gently squeeze on the silo and tie a piece of umbilical tape to hold the bowel down, so that you're creating a little bit of pressure on the intestines that are going into the abdomen.
And the baby's abdominal wall and abdominal capacity will increase dramatically from day to day, such that in the usual circumstance, within a week or sometimes substantially less than that, we can reduce the intestine into the abdomen, bring the baby to the operating room, remove the spring-loaded silo, close the fascia, the shrink layer, and then close the skin around the belly button, around the umbilical cord, such that a fairly normal appearing umbilicus is maintained.
All right, so that is the difference between omphalocele, gastroschisis, both abdominal wall defects. Omphalocele, the affected organs are born in a sac, okay, contained in a sac. Gastroschisis, they are not contained in a sac. Next thing we're going to talk about is myelomeningocele. Okay, so 1 in 1,000 pregnancies have neural tube defect. That's what it's considered, is a neural tube defect. Myelomeningocele has also been known as spina bifida. Okay, the severity depends on the location of the defect and how large the defect is. Again, in the last 10 to 15 years, they've developed fetal repair surgeries that have greatly improved the survival of the lower extremity movement. So these kids, the earlier they're treated, the earlier detection and the earlier the treatment, the less deficit they are born with. So we're going to watch a video on fetal detection and repair for myelomeningocele.
Once a family decides to pursue fetal surgery, things happen pretty rapidly.
All the components of our rather large team meet to discuss the case and then have the parents come in and we go through the entire process once again so that there's a clear understanding of what's involved and give them the opportunity to ask any additional questions.
We had to be down here, I don't know if it was 5 o'clock or 6 o'clock, but it was very early in the morning. I was so nervous.
Right. And, still a lot of consultations and things like that going on and,
Flurry of activity. They put an epidural in, was the first thing they were going to do, and I had to be awake for that. And you are knocked out for the surgery. And I remember bending over, getting that epidural, and they're talking to me, and all of a sudden you go, oh, I mean, if it hadn't hit us already, it hit me then. This is big time.
Right.
17 days before that, life was normal, and all of a sudden here we are in fetal surgery for something that's cutting edge.
We have a special OR that we use for fetal surgery. It's a very large OR because there's a lot of equipment that's there, and there are a lot of people involved in this. There are a couple of anesthesiologists. There's the fetal team.
2 to 3 surgeons in the room. There's a cardiologist in the room who monitors the baby's heart through the entire procedure. There's a neurosurgeon who actually does the myelomeningocele repair. There's an obstetrician or maternal fetal medicine specialist in the room who monitors the mother's uterus and performs ultrasound so that we make sure we put the incision in the uterus where we need to put it.
And it all has to be carefully choreographed so that everybody is focused on what their role is, what they need to do, but everybody has to work seamlessly together.
The mother goes under deep general anesthesia. Deep general anesthesia is important for at least 3 reasons. It anesthetizes the mother, anesthetizes the fetus, and also gives us very good uterine relaxation of the uterine muscle, which is very important for the operation. An ultrasound is done to look at the fetal position, and then a sideways wound is made, almost hip bone to hip bone, halfway between the belly button and the pubic bone, to expose the uterus. Oftentimes, the obstetrician will move the fetus within the uterus so that the myelomeningocele or spina bifida lesion is right underneath where we're going to make the cut in the uterus, because the baby basically stays inside the uterus during the operation. The cut in the uterus is done, again, under ultrasound guidance, sterile intraoperative ultrasound guidance, with a uterine stapling device that fires absorbable staples that pinch off all the blood vessels and keep the membranes around the baby tacked up to the muscle layer of the uterus. During the operation, the fetal cardiologist does monitoring of the fetal heart by echocardiography.
We're able to look at blood flow patterns through the heart, the various structures and the flow towards the different organs, heart function. We look at the heart rate. We're able to feed that information back to the surgeons and to the anesthesiologist that's managing the mother.
The neurosurgeon then comes in, and he and I do the myelomeningocele repair exactly like you would do in a newborn after birth.
I trim the sac of abnormal skin away from the nerve tissue. It's important to do that because that skin tissue, if I leave it behind, can become a cyst. It can be a problem later on. We then put the nerve tissue back into the spinal canal where it's supposed to be. And then I try to get a 3-layer closure. The first layer is the dura. That's the normal covering of the brain and the spinal cord. The second layer is the fascia. That's kind of like muscle type tissue. And then the third layer is the skin.
The goal is to cover the unprotected spinal cord so that it's a watertight, protective closure. It needs to be watertight for 2 reasons. One is that you want to stop the damage caused by amniotic fluid exposure for the rest of the pregnancy, and you also want to stop the leakage of cerebral spinal fluid out through the back that plays an important role in the development of hindbrain herniation and hydrocephalus. So if you stop the leak back here, the hindbrain can go back, and the hydrocephalus is less of an issue. Once the uterine wound is closed, the maternal abdomen is closed, including the skin, with a plastic surgical closure. All the layers are closed with an absorbable stitch that will dissolve once the mother's wound is healed.
So really, really cool developments in treatment of myelomeningocele, and then previously we talked about congenital diaphragmatic hernia, all by doing fetal surgeries. So very, very, very cool, much better outcomes. The reason that myelomeningocele needs to be repaired as soon as possible, he alluded to it in the video, is that when the nerves are exposed to amniotic fluid, it causes damage to those nerves. So that's primary, getting those covered and protected so that they can function normally. That's the first primary goal of the surgery. The secondary goal is to prevent leakage of cerebrospinal fluid, okay, because that can cause issues in the brain, such as hydrocephalus and et cetera, and development of the hindbrain. So there's still a possibility of paralysis. It all depends on when it was diagnosed, how quickly intervention was done, but again, gives that baby a better chance of an intact spinal cord and a more normal life. Next thing we're going to talk about is Pierre-Robin syndrome. Okay, so Pierre-Robin syndrome is a collection of defects or anomalies, such as cleft palate. Okay, so they have a hole or an opening between the upper palate and the nasopharynx. Retrognathia. Okay, so retrognathia means they have a small chin and it's recessed. Macroglossia is a very large tongue. They call these kids the profile. It's a bird face. Okay, so you look at them and their chin is really, really low and recessed. Their ears are usually a little bit low and rotated forward. But then they have a huge tongue, so it can block the airway.
Pierre-Robin sequencer syndrome is when kids are born with an abnormally small lower jaw, a larger than normal tongue for the size of the jaw, and sometimes cleft palate. About 2/3 of kids who are born with Pierre-Robin sequence have a cleft palate. The diagnosis of Pierre-Robin sequence is often made based on history and physical examination. Historical features such as difficulty breathing or stopping breathing during the night can occur. The other thing that we concentrate on is a child's ability to feed, because if a child can't feed, it's hard for them to grow. And the feeding and the breathing issues can go hand in hand. If your child has Pierrot band sequence, our team may decide to order a number of tests. One of the tests is a polysomnogram or sleep study in which we will measure the level of oxygen that your child is getting while sleeping. This also gives us some information about what the brain is doing while your child's sleeping, as well as the heart and the lungs. Another important test to do is a microlaryngoscopy and bronchoscopy, which is a test in which we stick a very small fiber optic camera into the airway and watch your child breathe. This gives us a lot of information about the anatomy of the airway, which will help direct care as we move forward. The last test we might order is an X-ray of the head and neck, which will give us information about the anatomy of the jaw, as well as its size relative to other structures of the head and neck. Because there's a wide variety of patients who have Pierrot band sequence, there's also a wide range of treatments. Most mild cases of Pierrot band sequence can be treated with prone positioning alone. That's when a child sleeps facing downward. By sleeping facing downward, the base of the tongue is brought forward, which will allow them to breathe more easily. More moderate or severe cases of Pierrot band sequence are treated with either tongue lip adhesion, mandibular distraction, or a tracheostomy. Tongue lip adhesion is when the undersurface of the tongue is sewn to the lower lip. This brings the tongue base forward and can be applied in moderate cases of Pierrot band sequence. Mandibular distraction osteogenesis is a technique in which we actually elongate the abnormally small jaw. By bringing the chin point forward with this technique, it drags the tongue base forward to relieve airway obstruction. Our plastic surgery team has a tremendous amount of expertise in treating Pierrot band sequence. We offer the full range of treatment modalities that are used throughout the United States and the world to treat this problem. If your child has Pierrot band sequence, they may see a number of different specialists here at CHOP. Our team has an extensive experience with this, and in fact, we're one of the largest volume centers in the country. Our multidisciplinary team of experts creates a customized treatment plan for every child. And then we reevaluate as they continue to go through childhood and grow, so that at every time point, we optimize their outcome.
All right, so that's Pierre-Robin syndrome. Next one we're going to look at is something we're all familiar with, or I would assume you are, is Down syndrome. Okay, so Down syndrome has a wide variety of features that can be associated with it, but not all children with Down syndrome have all of these features. So Down syndrome happens in 1 in 800 births. It's also called trisomy 21 because that baby's getting an extra genetic material from the 21st chromosome. Down syndrome is the most common chromosome abnormality. People with Down syndrome can have high functioning all the way down to low functioning. But across all people with Down syndrome or trisomy 21, they have an average IQ of 50. Okay, so there are some very low functioning people with Down syndrome, some extremely high functioning people with Down syndrome. This picture right here tells some of the physical or outward appearance aspects that you can see in patients with Down syndrome. So upslanting palpebral fissures, okay, so that is your eyes, they're kind of slanted up, okay. Microtic low set ears, okay, so ears are a little bit small, they're low set on the side of the head, and they can be rotated forward, so the lower lobes are a little more forward than you would think. Brush field spots. This is actually in the colored part of the eyes, and it looks like someone took a paintbrush and made brush spots from the center out. Flat nasal bridge, hypoplastic maxilla. Okay, so the nasal bridge doesn't go out or down and out. It's very flat. Macroglossia. These kids have very large tongues, and then their tongues will protrude. It's kind of like an automatic thing. Their tongue goes in and out, in and out, in and out. They have what's called a sandal deformity. Okay, so this is, looks like they've been wearing thong sandals with really wide thong part, but they're born like that. And then a simian crease. So if you look at the palm of your hand, you have 3 different palm marks in the middle of your hand. People with Down syndrome have 1 crease straight across called the simian crease. And then excessive nuchal folds, the back, they have excessive fatty skin on the back of their neck, and it's just, it folds and folds and folds. So those are just some of those exterior things that you might see in someone with Down syndrome. But again, not every patient with Down syndrome has all of those physical aspects. Some of them do, some of them do not. So again, not all patients with Down syndrome have all of those physical aspects. There were actually some in the video that aren't on this picture. The only definitive diagnosis is to draw blood and look at their genetic makeup. It can be diagnosed in utero with amniocentesis. So that's actually, just due to our progressive being able to test finer and finer and finer detail. Last thing we're going to talk about, well, no, second to last thing we're going to talk about is cleft lip and palate. Super important for respiratory therapists because we do get involved in treatment of patients with cleft lip and palate because they have a very high chance of aspiration. Okay, so part of the lip or palate or both is not formed, and there's an opening or connection between the two. It can be very simple, such as just a hole in the lip that can be closed with a primary closure. It can be extremely complicated, such as this picture down here. Okay, bilateral cleft lip with full palate involvement. Okay, so there's just openings everywhere. So this little table here kind of gives you an idea of here's normal, here's just a cleft lip, bilateral cleft lip. Okay, those can usually be surgically repaired, easy. Cleft palate, so there's just a hole in the upper palate. Okay, cleft lip with partial palate involvement, and then bilateral, which is extremely complicated. A friend of mine had, her youngest son had an extremely complicated bilateral cleft lip and palate, and to date, he is in his 20s and has had 18 surgeries. And still, technically, needs to have one more surgery, but he probably will not have it because he is kind of over all that. So we're gonna watch a video on cleft lip and palate repair, some really, really cool advancements that they've made.
Nasoalveolar molding, or NAM, is a treatment option for children born with a complete cleft lip and palate. At Seattle Children's Hospital, specialized orthodontists offer NAM therapy for infants with unilateral, bilateral, and mixed clefts. NAM treatment begins as early as the first week of life and continues until the primary lip repair at approximately 6 months of age. The goal of NAM treatment is to reduce the severity of the cleft prior to lip surgery by closing the gap between the lips and gums and improving symmetry of the nose. The surgeon is then able to repair the lip more easily, resulting in a smaller scar with less tension on the lip and an overall better result. To begin NAM treatment, molds of the infant's nose and mouth are taken while the infant is awake. These are used to fabricate a custom appliance, which is then adjusted as the infant grows. Cheek pads are placed outside the crease of the nose to protect the baby's skin. A base tape is then used to help close the gap between the lips. For a unilateral cleft, the tape should be applied first to the non-cleft side, then stretched across the cleft while squeezing the lips together. The molding plate is inserted at a 90-degree angle and rotated into the mouth. Using one finger to stabilize the plate, 2 additional retention tapes are then used to secure the device in place. Parents are taught how to make the tapes so they can do it themselves at home. This is an example of 2 retention tapes and the longer base tape, which would be used for an infant with a complete unilateral cleft. Parents are given supplies at the beginning of NAM treatment and at every visit as needed. NAM visits occur weekly or bi-weekly. At each visit, the orthodontist will make changes to the appliance to gradually mold the lips and nose. When the gap between the gums has been reduced to approximately 5 millimeters, a nasal stent is added to the molding plate. The soft pink acrylic of the nasal stent should rest on the nostril rim to lift and shape the nose. Infants can be fussy at the first few visits as the appliance is inserted and removed. However, the appliance is not painful, it's just something new, and they often calm down within a few minutes. Occasionally, a child's cheeks may appear red or irritated as a result of taping. This generally heals quickly, but parents should notify their doctor, as alternative materials can be used. Infants are often comfortable eating and sleeping with the NAM appliance in place. Seattle Children's Hospital is proud to have skilled orthodontists on our craniofacial team who provide NAM therapy and can care for patients with cleft lip and palate at every stage of their development.
So again, that's just really, really cool improvements in treatment of cleft lip and palate. So the numbers of surgeries have been greatly reduced with these new therapies. Last thing we're going to talk about, and you're going to definitely see patients with cerebral palsy. So cerebral palsy is a permanent non-progressive disorder. Causes physical disability and development, mainly affects body movement. Most patients with cerebral palsy are incredibly intelligent. I had a friend in college who had cerebral palsy. He was effectively a quadriplegic. He was in a motorized wheelchair, but he also had a PhD. He was just absolutely brilliant. The major problem that patients with cerebral palsy have is they end up getting potential for pressure sores or for pneumonia because they can't cough effectively. It mainly affects body movement. Okay, it's a central motor dysfunction affecting muscle tone, posture, and movement. It's permanent, non-progressive defect or lesion of an immature brain. It happens very often in our extremely premature infants. Cerebral palsy is not genetics. It's not genetic. It's not infectious. But once it's there, it's not reversible. So if you come in contact or if you take care of a patient with cerebral palsy, they could have a very wide range of abilities and a very wide range of what they can do, you know, their potential. So keep in mind that just because they can't move like other patients can, just because they don't necessarily have conscious control of their movement doesn't mean that they are not intelligent. Most of them have absolutely zero deficit as far as their IQ or their intelligence goes. So that is what we're talking about today. And I hope you guys have a great week.